Well, Happy New Year and welcome to Quinnipiac University's COVID-19 Community Conversation, Empowering Communities, Informing Decisions. My name is Janelle Chisera, Dean of the School of Health Sciences at Quinnipiac University, and I'll be serving as the moderator of this conversation tonight. You know, the last time we met, which was December 17th of 2020, the Food and Drug Administration authorized Pfizer's COVID-19 vaccine for emergency use, clearing the way for millions of people to begin receiving the vaccine. On that very same day in 2020, the FDA Advisory Committee was considering a second COVID vaccine from Moderna, which we now know has been approved, delivered, and administered. What hasn't changed since December? Regardless of whether you feel sick or whether you've received the vaccine, wear a mask, wash your hands regularly, and stay socially distant. That advice from the Center for Disease Control releasing findings recently showing that 59% of all transmissions came from people without symptoms. Fast forward to the new year. As of Wednesday evening, more than 21.2 million people across the US have tested positive for the virus, and over 365,000 deaths have been reported. Most days since early December, the United States has added more than 200,000 new infections daily. But there is some good news here. As of January 6, we know that we have 2 vaccines approved for emergency use in the United States. 17.2 million doses of the vaccines have been delivered across states in our country, and 5.3 million of those doses have made it into the arms of US citizens. Although we are far behind the goal of 20 million doses, which was the 2020 year-end goal, we have taken an incredibly important step toward what we discussed last time as herd immunity. In Connecticut, we were allocated 211,000 doses of the vaccine, and as of January 4th, at least 75,900 doses have been administered in Connecticut, covering 30% of the prioritized population and 2.1% of the state's total population. That 2.1% put Connecticut as one of the first 9 states in the country to vaccinate more than 2% of its population. While surrounding states have struggled to get the COVID vaccine administered, Connecticut has really hit the ground running as soon as the vaccines landed in the state, ranking first in New England for vaccine distribution. While it has only been a short 21 days since our last community conversation on COVID-19 vaccines, enough has certainly changed regarding not only the virus, but also the vaccines that may have left you with questions. Again, we are here today to help answer your questions. I am so incredibly honored to have our esteemed panelists with us here again today, providing expertise in medicine, law, biomedical sciences, business, nursing, and social work. We are very honored and happy to have a special guest with us today, Dr. Reginald Eadie, CEO of Trinity Health of New England and co-chair of the Governor's Vaccine Advisory Group, who will be able to help provide the most up-to-date information regarding vaccines and vaccine distribution in the state of Connecticut. If you have a question about COVID and or its vaccines, you have come to the right place. I am certain we have the experts at the table to answer the questions that you may have. This is the second community conversation in a series of webinars we'll be hosting over the next few months as we work through this pandemic together. The purpose is very simple. It's to be here to answer questions that you have, and more importantly, to provide you with sound scientific advice and data-driven recommendations. If you missed out on our previous conversation, please do visit the link that we're going to put in the chat for you so you can listen to that prior conversation. Panelists, I'd like you to take a moment to briefly introduce yourselves. Dr. Hill.
Good evening, and thank you for joining us. I'm Dr. David Hill. I'm a professor of medical sciences in the Netter School of Medicine at Quinnipiac, and I also serve as the senior medical advisor for COVID to the university.
Thank you. Dr. Doyle.
I'm Maya Doyle. I'm an associate professor of social work at Quinnipiac, and I've worked in healthcare for about 25 years.
Dr. Eadie.
Good evening, Reginald Eadie. I'm president and CEO of Trinity Health of New England, most of the Catholic hospitals here in the state of Connecticut, and am honored to be a co-chair of the Governor's Advisory Group. I look forward to the conversation.
Great. And our resident lawyer here, Professor Thomas.
John Thomas. I teach health law, among other things, at the law school. I also have a public health degree and spent 10 years teaching in a public health school.
Dr. Mittal.
I'm Jeff Mattal. I'm a microbiologist and immunologist and professor of biomedical sciences.
Dr. Kuchara? I'm not sure if I heard.
Sorry about that. Lisa Kuchara, professor of biomedical sciences in the School of Health Sciences.
Thank you, Lisa. Dr. Peterson?
Good evening. I'm Mary Peterson. I'm the clinical assistant professor of nursing in the School of Nursing and also the director of the accelerated nursing program here at Quinnipiac. And I'm also a pediatric nurse practitioner.
And Dr. Norvis?
Good evening. I'm Mario Norvis. I am a professor in the School of Business, Department of Management, and my area of specialization is supply chain.
Great, thank you very much. Before we begin, I would like to go over a few important webinar points. First, this presentation will be recorded and available on demand shortly after it's completed with transcription. Second, we encourage you to engage with us by asking questions in the Q&A feature that's at the bottom of your screen. You can ask questions anonymously, or you can ask them by using your name. Finally, if you see a question that comes up that's relevant to you, you can upvote that question by hitting the thumbs up icon, and that will cause that question to jump to the top of the Q&A box, and we can hopefully get to that question sooner rather than later. So panelists, welcome. Let's get right to this. Professor Kuchara and Professor Mittal, you both gave a great introductory description of the COVID vaccines the last time we met and how they are intended to work. At that time, you described the vaccine from Pfizer and said that the description is pretty much the same for Moderna. So I want to bring us to today. Where do we stand regarding vaccines that are approved and those in the pipeline? Specifically, are there differences in action regarding those already approved and those that are potentially soon to be approved? Lisa, Jeff?
So as you said, the Pfizer and the Moderna are being used for an emergency use right now. And those are both RNA vaccines. There are some advantages to those vaccines in that they can be kind of quicker made, and they are something that we could ramp up. And as I'm sure people will ask later about variants, because it's a question that is on a lot of people's mind, it's a lot easier to be able to adjust those vaccines. There are 3 in the pipeline that are close. They are in phase 3 trials. So they've gone through phase 1 and phase 2, and they are now in phase 3. One of them is the Oxford AstraZeneca vaccine. You might have seen that in the news because some countries have started using that vaccine. We are still in phase 3 right now, and that has not gone to the FDA yet. Another one is the Johnson & Johnson vaccine, and those 2 are similar to each other, but different than the current RNA vaccines. Those 2 are adenovirus-based vaccines, so they're very different approach to the vaccine themselves. One of the biggest difference practically to us is that it's going to be something that can be stored in the refrigerator, so it has a little bit of a different stability. Certainly important for rural areas, but also important worldwide as well. And then the 5th one that is in phase 3 trials right now, the 3 that are in phase 3, is the Novavax vaccine. And that one is a protein-based vaccine that the data should be coming up. They said January, so it should be coming up for review very soon.
So, Lisa, how soon do we anticipate those in the pipeline being approved? You did just say soon that the data will be coming out. What does that mean from an approval process? When can we expect those?
So as they go through phase 3 data, they have to basically have enough of that data that is something that they can submit to the FDA to be approved. So it is something that you can't really rush the science on it. So to say exactly when that data will be available is hard. It kind of depends on how many people in the groups actually get infected. Sometimes when we have a more rampant viral infection, it actually helps to speed up a phase 3 trial. If the virus suddenly went away, like SARS did, all of a sudden you don't have enough data to be able to finish those studies because you don't have anybody getting infected and you can't determine efficacy anymore. But it appears so far that the efficacy is at least at the target for all of the 3 vaccines that are in the pipeline. The question is, will they be quite as good as the efficacy as the Pfizer and Moderna, which are 94.5 and 95%. So that's the data we're waiting to determine. But it seems that it's just a matter of waiting for the companies to complete the phase 3 and submit that data to the FDA. And we know that that's part of Operation Warp Speed. It's not necessarily in the making of the vaccines, but it's in the getting that vaccine to the FDA and getting it approved.
And I'll just add a quick comment there
Go
that,
ahead, Jeff.
similar to what Dr. Kuchara said, typically for these vaccines, for them to have enough data for the FDA to review and approve, you need a certain number of people in the clinical trial to be infected. So the surge that, that we're going through right now might hasten the data a little bit, if you want to look for a very small silver lining and an increase in cases.
Thank you, Jeff. I appreciate that. So, I have a question with multiple vaccines coming up, and I've heard this before, people asking this question, will I have a choice as far as the vaccine that I can get?
So not at this point. At this point, you want to get the first vaccine that is offered to you. If they've gone through the process of being approved by the FDA, which means they've gone through phase 1 and phase 2 and phase 3, they've determined to be, have effectiveness. We know their efficacy, we know that they're safe. So at this point, there will be no choice. You're not going to be able to say, I want to be able to wait for a certain kind of vaccine. Now, certainly, maybe later on down the road, there might be a reason why a certain population, it might be better to get a certain vaccine. We know with the flu vaccine, certain vaccines are better in children or in older adults. So far, these vaccines seem to work equally well in older adults, so there doesn't seem to be that discrepancy. But that is something that as they, become more prevalent and we're not as in demand for them, that there might be that ability, much later down the road, but not now. If you're offered the vaccine now, take the one that you're offered so we can start that path down your immunity and community immunity.
Great, thank you. And then we spoke about this at our last conversation, but I do want to get to it again. I want to get a little bit of an update on what kind of immune response one can expect from any of the vaccines upon administration.
So an immune response after a vaccine could actually leave you feeling kind of scientifically, icky. You actually, have a chance that you might actually experience a fever, or experience achiness or fatigue. It happens in about 15% of the people according to the clinical trials. Although the people that I know that have received it, it seems to be much less than that. So, but it actually means your immune system is working. So when our immune system recognizes something that is foreign, it's going to actually start making chemicals called cytokines. And those cytokines could actually make you feel kind of not so good for a short period of time, maybe 1 to 30 hours. So I know a few people that were involved in the clinical trials, and they were actually looking forward to having that achy feeling because it kind of meant they got the vaccine and not the placebo. So they were kind of using that as a way of being able to gauge in a non-scientific way, because obviously 85% of the people don't exhibit those immune response symptoms. So they didn't know for sure, but they felt if they kind of felt those immune response and kind of felt icky for a day, that it was a better chance that they had gotten the vaccine rather than the placebo. But it is something to be prepared for. My stepdaughter's getting the vaccine tomorrow, and I said, well, what are you doing Saturday? Just be aware you might not feel so good. And I think we have to be upfront about that so people know about that. But the symptoms are, minor. They go away after a very short period of time, and you should actually view it as a good thing. It means your immune system is working.
Great. Lisa, thank you. I want to shift the conversation slightly, and I want to turn it over to changes in the virus. So specifically, I understand that there are COVID-19 variants circulating globally. In September of 2020 in the United Kingdom, a new variant has emerged with an unusually large number of mutations, and that variant has been detected in the US, and just today, 2 cases of the UK variant have been detected in New Haven County. In October of 2020, in South Africa, another variant has emerged independently of the one detected in the UK. And recently, the CDC mentioned another variant identified in Nigeria. So Lisa and Jeff, this is kind of going to be a loaded question, but the theme of this loaded question really is around what does this mean? Is the development of a variant expected from a virus? How different are they from the strain that we've been fighting with over the past year? And more importantly, what does this mean regarding the effectiveness of the vaccines to combat the virus?
So yeah, variants in viral infections are incredibly common, so it's expected without a doubt. The variants come from mutations, and mutations, humans could have mutations. We need to think of mutations as changes in our DNA. These could be advantageous. We could think about there are certain mutations that make us less likely to develop diabetes. You could think of mutations as being disadvantageous, mutations that accumulate and could lead to cancer in humans. The same thing occurs, these mutations occur in the coronavirus. The coronavirus genome is RNA versus DNA, which actually means it's going to acquire mutations more rapidly. And the mutations, just like in humans, these mutations occur randomly, but they could result in an advantage for the virus or a disadvantage. And when we talk about advantages and disadvantages for viruses, it's more, do they increase transmissibility? Do they decrease transmissibility? And that's primarily what we're looking at with the UK and the South African variants, is that they appear to increase transmissibility. So they make it more likely to be transmitted from one person to another. The variants that we're looking at, we're primarily looking at changes in the spike protein, which is how the virus attaches to human cells. It's also the protein that is the focus of the vaccines that we have, or at least the current vaccines. So while there are a number of mutations, there are only very few mutations in the spike protein, which they think make it more able to bind tightly to human cells, which makes it more infectious. However, the spike protein, these are large proteins, and we're talking about very small changes to the protein. So, 1 or 2 amino acids out of about 2,300 amino acids for the, 1,200 amino acids for the spike protein. So we're talking about about a 1% change in the spike protein. So the rest of the spike protein, even in these variants, is the same. So we would not expect the vaccines that have been developed to be ineffective against these variants.
So Jeff, I hope I heard that correctly. You said you expect the vaccines to be effective for even these variants, that the UK variants that we're seeing here in the state, correct?
Yes. So we would. Okay. There's been no evidence that the vaccine is going to be less effective against these variants. You have to think of the spike protein kind of as, if you picture it as a Rubik's cube. You have this spike protein on the surface of the virus. It's a Rubik's cube. It has 6 different sides, different colors, red, green, blue, with 9 different squares. Our body's going to make antibodies to the green side and the red side and the blue side. The red side antibodies might not bind to the blue side, and the blue side antibodies won't bind to the red side. What we're seeing in these variants is really kind of one change in one square on one side of the spike protein. So while the blue side antibody may no longer work, and we're not even sure that that's the case, we have other antibodies to other parts of the spike protein that should still protect us from infection.
Great analogy, Jeff. Thank you so much. So far, more than 5.3 million COVID shots have been given out, but that is just a fraction of the 20 million initially expected at the end of 2020. With US vaccination numbers behind schedule, some are floating the idea of how the US can speed up the vaccine rollout. One of the ideas involves giving half doses of the vaccine, and the other involves a plan that may potentially lead to delays in the administration of the second doses. So I kind of want to clear the air here. And Dr. Hill, I was wondering if you could get us started on this one. How were these vaccines approved to be used? And is there any interest in splitting doses in half or delaying the second dose to allow quicker distribution within the state of Connecticut?
So this is a great question. Everybody is waiting in line, I think, to get their vaccine. I'm certainly looking forward to the day that I got my call to go in and get the vaccine. And so we're all wondering, is the distribution fast enough? How long are we going to have to wait to this? So can we be clever about how we give the vaccines? Any trial with a drug or vaccine is very specific in how that trial is designed. It's designed in terms of the dose. So there are different doses of the vaccine or a drug that are given. They're given at different intervals, particularly for vaccines. Most vaccines are given separated by a month. These 2 vaccines, the 2 doses are 21 and 28 days, because that's the appropriate time for you to develop your initial immunity, and then you get boosted after these 3 or 4 weeks with a second shot. So the doses are very specific. They've gone through many individuals who have been put into the trials. These have been determined very carefully. So to deviate from that, we're just not sure if you cut the dose in half or you extend the interval, how the response would be. And at this point, with these emergency use authorizations by the FDA has come out very strongly. Matter of fact, they came out on Monday saying we should not be extending the dose intervals. We should not be mixing vaccines. We should not be cutting the doses in half to try to make this go further. So the issue is not so much about the numbers of doses for us. It's really been in the implementation of that. And actually, I was listening to the NPR on vaccines earlier this week, and they gave a shout out to Connecticut as being one of the states where distribution has been fantastic. But many states, because there really hasn't been federal guidance on how to roll out vaccines, have not done as well as we have in Connecticut. So I think we're working hard to get the vaccines to those who need it first, and each of our turns will come up. But we really should not be playing with the science. The science has been very careful. The FDA has reviewed this and said, this is the way these vaccines should be given, and let's not deviate from that. And I think it might be really a good segue to have Dr. Eadie just talk about how well Connecticut has done and why we've done so well.
Yeah, so thank you for that. I think, first of all, I think our governor is an excellent leader. For someone who's not in the same space that most of the panelists are in, he had the wherewithal to say, okay, well, let's grab a couple of people, let's entitle them as co-chairs. And then the commissioner decided to create 3 subcommittees, one subcommittee being the scientific subcommittee. And to piggyback off of your point, we posed that notion to the scientific committee, and they, as you indicated, didn't support it. And we agreed that following the science was the way that the governor's advisory group would proceed. The second subcommittee being the allocation subcommittee, which is where a lot of the conversation now and attention is being drawn. And so their job is to decide who gets it and when. And we have agreed that they will follow the recommendation, at least as a base from the ACIP. But just as in phase 1A, you may recall that we took the ACIP's recommendation, but we added first responders, and we defined those first responders. So a little change in the guidance that we received. Then the third is the communication subcommittee, and their primary role is just that, to communicate to the state and its citizens exactly what we're up to, who gets it, when they get it, how they get it, etc. So I think that really speaks largely to, we have brilliant men and women participating on the 3 subcommittees as well as the advisory group. And that mix that we were fortunate enough to put together is working.
Dr. Eadie, I was wondering if I could dig into this just a little bit. I want to talk about vaccine rollout. And Connecticut, I know, is currently in phase 1A of vaccine rollout and really has done a phenomenal job with that. And that includes healthcare personnel, long-term care facility residents, and first responders at risk for exposure to COVID. That phase will last, I believe, the last time I read it, till late January, early February, maybe. And the state of Connecticut website really does a nice job of explaining that phase, I think, to your point of the communication subgroup. But I really want to get right to the upcoming phases, specifically phase 1B. There isn't a lot of clarity on the website regarding that phase at this point. So I want to be specific here, if I may. What groups are being considered in phase 1B? How many people do we think are part of that group? And how long do you anticipate that phase to roll out?
Sure. Yeah, great question. So the reason why the website is not clear from direction from the communication subcommittee is because it is not definitely, or definitively, I should say, been finalized. If anyone participated in the governor's press conference today, you saw a slide where he said at this point, and things will be finalized in the very near future, we believe that 1B will include ACIP recommendations, as we will always start off with, right? So we're talking about citizens that are 75 years old and older. And then we're going to start including frontline essential workers. And we have, I think, done a good job in agreeing with the ACIP and defining who that is. We also are going to exercise our flexibility because it's got to work right for the state of Connecticut, of course. So we have introduced to the governor a recommendation around considering people who are in close proximity in settings. And so that's one. And then we also have entertained or nudged him to remember the communities in which morbidity and mortality rates are higher and disproportionate to the remainder of the state. So in addition to those, we also have asked him to consider that. And right now, the allocation subcommittee is going to be having, I think, subgroup conversations maybe tomorrow, but the next subcommittee meeting will be on Tuesday, where we will discuss definitively what the recommendation will be to the advisory group. And then the advisory group will make that recommendation to the governor.
Great. So Dr. Eadie, I take it that once those decisions are made, that website will be updated just like it was for the first phase, which actually was very clear on the website.
You're absolutely right. You know, phase 1A was very easy, I would suggest. You know, it's not hard to figure out who a healthcare personnel is, particularly as it has been defined, and then those residents in long-term care facilities, right? So nursing homes, et cetera. I mean, that population was chosen, I think, because the science suggested it be chosen. But as we go now into the general population, as we approach phase 4, things are going to be much more complex. And you can imagine the amount of work and how difficult the work is going to be for the subcommittees moving forward.
It is no small task, Dr. Eadie, you know, even thinking about what it takes to get the vaccines, not just distributed to the states, but then into the arms of the citizens of the state. It's really, it's quite fascinating to watch. I believe I understood that teachers are going to be considered to be included in phase 1B. And I was curious, you know, of course, we're from Quinnipiac University. So I'm wondering whether phase 1B has teachers included, and if that includes university faculty.
Yeah, so teachers are there, and it will include faculty at Quinnipiac University. That's in the event that nothing changes between our last meeting and the next allocation subcommittee meeting. So I can't speak definitively because it's up to the subcommittee to make those recommendations to the advisory group, and then we will then give those recommendations to the governor. But I'm pretty comfortable saying that, you know, because we're following the guidance received by ACIP, that the professors participating in today's panel will qualify for 1B.
Wonderful. Dr. Eadie, I want to press this just a little bit, if I may. What about facilities workers and staff? I know we're talking about teachers, but there are other people that are in our institutions that are facility workers or staff who were curious about whether or not they'll be included in phase 1B.
Yeah, so that again will be discussed further. I mean, you know, there are a number of advocacy agencies that are I'd say lobbying all three of our subcommittees, as well as the governor's office and the advisory group. And so everyone's raising their hand saying, what about us? And we want to go next. So we're trying to, again, follow the guidance we're receiving from the CDC's ACIP primarily. And then secondarily, we're looking from a Connecticut lens, understanding, you know, how do we, and the governor went over this today, how do we, what decisions can we make to mitigate morbidity and mortality within the state of Connecticut? And how do we get to herd immunity as quickly as possible? And then how do we consider those high risk communities? And those three, what I'll call, you know, goals, those three goals we apply to all of our conversations. And hopefully if we get this right, in addition to the data, it leads us to the right answer for those kind of questions.
Great. Dr. Eadie, excuse me if I missed this, but did you mention how many people, how many people we thought were in phase 1B and about how long it would take to roll out?
Yeah, so we think that 1B, which will start, which will be added to 1A. I've got to be careful to say because I've been confusing people in the past. So 1A will continue throughout this entire process. We will be adding 1B. We think 1B right now has about 880,000 Connecticut residents. And we also think that we're thinking that, you know, vaccinating at least 60% of them before we start phase 1C is ideal. And so that will probably take anywhere between 9 and 10 weeks. But again, rate limiting factors include the availability of the vaccine, so we don't control that. Second, it also includes the likeliness that someone in the citizens in the state will roll their sleeves up and accept the vaccine. So all those factors play into how soon we get out of or into a subsequent phase.
Perfect, Dr. Eadie, thank you. I have a question regarding the vaccinations. The state is recommending, and again, I was at the website, it really is a great website. The state is recommending that people stay in communication with their employers for information about vaccinations. For those in congregate settings, they tell people to stay in touch with their facility leadership. And then they tell others to stay in contact with their medical providers regarding vaccinations. Some people are struggling a little bit getting through to their medical providers, and some don't have medical providers at all. Who should they contact, or where should they go to find out how to get the vaccine and where they're supposed to go to get it?
Yeah, so that's not surprising. I mean, when you think about the social determinants of health, access, which includes providers, insurance, et cetera. I mean, access is a challenge. We anticipate that now that the vaccines are available in the state of Connecticut, we've got to consider the social determinants of health. So, I'd say to your listeners and to the entire state, you've got to stay tuned, meaning you've got to sort of keep your ear and eyes open to understand what's happening so that you don't miss out in getting vaccinated as soon as you're ready to do so, or as soon as you're eligible. So, I would advise people to, like many people did today, record and or watch the governor's press conferences. There's a lot of information there. I think he does a great job in making it easy for our citizens to understand. Watch your local news. That's always important. As you indicated, visiting ct.gov, the state's website, always has if you can navigate the website, it has a great amount of information. You're always welcome to go to Trinity of New England's website. We do a good job, I think, in mirroring what the state's website has. Plus, we have access to information a lot sooner because of the role and myself and others play on making decisions. Of course, you mentioned asking your PCP. And then, of course, you can go to ct-n, I think, .com, which is the CTN, which airs, records and airs and stores the subcommittee and advisory group meetings. So anyone who wants to go and look at Tuesdays, for example, just going to CTN's website and see that conversation. A lot of you can see what was discussed, and you can see or learn of answers to a lot of your questions.
Great. Dr. Eadie, thank you so much. I want to turn this a little bit to a question that we actually started the last time we met. I understand that clinical trials for the vaccine included young adults and adults. And we asked the question last time, what about children? So I was wondering, Dr. Peterson, do we have any update on the vaccine for children?
Yes, at this point, we know the Pfizer vaccine is indicated for young adults down to the age of 16. The Moderna vaccine is indicated starting at the age of 18. At present, there are clinical trials from both companies being done in that pediatric population, ages 12 to 16. They're looking into that. It's important to understand that the pediatric immune system responds differently than an adult. And so there's challenges in doing this. So at this point, they are down to the age of 12. Once it is approved, and it looks like it most likely would be for 12 to 16-year-olds, then they will start to do clinical trials in that younger population. We are aware that the pediatric population, right, doesn't get as ill. There hasn't been as much serious illness in the pediatric population as there have been in adults. So the focus is really getting it to the people that need it first. They are, at children down to age 16 can be receiving the vaccine, but they're not in one of those initial groups out there. So thinking ahead and looking into when the pediatric population will start to be getting the vaccine, most likely we're probably looking more towards the end of 2021 with that population.
Great. Dr. Peterson, Thank you so much. I want to shift the conversation just a little bit to coronavirus and college campuses. And Dr. Hill, I wondered if you could help us out with this one. Since last fall, there's been a narrative emerging regarding the spread of virus into communities because of college campuses. After schools opened this past September, the Wall Street Journal rushed to publicize a preprint study saying that in-person college was fueling a rise in cases. Other articles followed suit, suggesting that campuses are major super spreaders. So again, David, Dr. Hill, I think I want to clear the air here based on the data. So does our community need to be concerned because our students pose a threat? And how do COVID-19 virus rates compare to the national average?
That's another great question. And I will just start out by saying that Quinnipiac is very, very aware of our relationship to the communities that surround us, particularly North Haven and Hamden, but also farther afield. And we always want to make sure that we're good citizens for our communities. So I'll start out by saying that our students in the fall and for this spring term will come back to Quinnipiac COVID-free. Because of our testing plan, we're going to test all of our students before they arrive. We're going to test them as soon as they arrive. Literally, as they're driving in, we're going to have them drive through and we're going to get the sample. We're going to, let's say, contain them. It's kind of a loose quarantine for the first 1 or 2 weeks. And then we're going to test them a third time after that. And then we're going to test basically the entire undergraduate community once a week throughout February. So our students are coming to Quinnipiac COVID-free, and we're going to work very hard to try and keep them as COVID-free as possible throughout the semester. But I think our universities more likely reflect what's going on in the community, so that if the community has high levels and we realize that our students will be going out into the community, they are likely to acquire that if they don't follow all the prevention guidance. But we test all of our students. So we're testing those who are symptomatic, we're testing those who are asymptomatic. So we're able to say that, we have X number of students who are positive, whereas that kind of testing really isn't done in the community. The testing in the community is only done when you're primarily symptomatic. So if you look at the data for us and for overall, I think we're a little more than 1% of our students were COVID positive throughout the semester. If the Broad Institute, which is doing testing for many New England universities and colleges, had a rate of a little less, I think, than 1%. But if you look at the national prevalence, or in Connecticut, right now in Connecticut, the prevalence of COVID is 6.5%, and that's probably an underestimate given that many people are likely to be asymptomatic. So I think as we consider the impact of Quinnipiac on the community and vice versa, we want to be good citizens. We're going to do everything we possible to bring back a student population that's as COVID-free as we can manage, and then work hard to keep them COVID-free. But we're all part of the same community. And if there are lots of COVID in the community, our students are probably going to acquire that through the period of time. But I'd like to think that our students aren't going to be super spreaders throughout the community.
Great, Dr. Hill, thank you. In addition to all that testing, we also have things in place as the CDC has recommended regarding wearing masks, washing hands, socially distance, classroom settings, remote learning, hybrid learning, things like that, that create that safe environment. Thank you, Dr. Hill. I want to go ahead and open this up for questions that have been posted into our Q&A box. So I'm going to turn this over quickly to Colleen to get to some of our questions from people who are participating today.
Sure. Hi, everybody. Thank you so much for coming. I'm Colleen Thompson, one of the assistant deans in the School of Health Sciences, just helping to moderate all of your wonderful questions for our panelists. And you're all doing such a great job. This is terrific. We're back to the vaccine. So you know that the questions are coming in fast and furious about the vaccine. And one of the first questions here is about whether any of you who want to try this one out think the vaccine will become a requirement for medical professionals down the road, similar to, we all know the flu vaccine is required for healthcare professionals. And then to add on to that, maybe will it be a requirement for residential college students, for our students out on clinicals? Does anybody want to give that a try?
So I'll jump in first on this. Yes, I expect that this vaccine will be a requirement for healthcare personnel, both to protect themselves and to protect their patient population. And when it receives full approval, I imagine it'll be a requirement for our students coming back to campus. So as we move from emergency use authorization to general approval of the vaccine, I see that requirements will come into place for this. We're all looking forward to the time when we can be more open with each other, and that's really not going to happen until we have high volume vaccination in the community. And I don't know if Professor Thomas wants to just talk about some of the legalities of vaccine requirements.
I think you've covered it well as usual, David. Yes, we can't require it in the employment context or healthcare context until the vaccine receives full approval. And we're probably some months away from that, maybe a year away from that. But I concur with David, given my public health training, that eventually this will become a mandatory vaccine in a number of settings, including, of course, healthcare. Many employers eventually, once the vaccine receives full approval, require it, and of course, also in educational communities.
And I'll be happy to add to that, and to that end, because of that, the governor and the advisory groups are not having conversation around mandating or recommending a mandate for the state of Connecticut.
Great. Thank you. Colleen, do we have any other questions?
We do, absolutely. Thank you for those responses. Someone has an interesting question, I guess directed at many of you on this screen right now. How do healthcare providers and educators encourage vaccination? What's our job here to get to that herd immunity, especially for those that are vulnerable?
So I do some research on this pre-COVID of just, how do we talk about it? How do we have conversations about vaccine hesitancy? It's natural to be hesitant. This vaccine has been in the media quite a bit, and that can generate some concern. So it's natural to have questions and concerns, to be hesitant. It's important to get the answers from people who are reputable and from science sources. So what we can do is, if we are going to get vaccinated, I have seen slews of people posting pictures of them getting vaccinated or them with their card. So that helps to show immunity going viral, and that our healthcare professionals and soon our educators in the next lines of people getting vaccinated, show that they're getting vaccinated. So that helps a lot. The other part, I think, is just to, when you hear questions, no matter how strange some of the questions are, to just take a deep breath and answer them respectfully, because we've heard all kinds of strange things. And if you laugh at them or make fun of them or make them feel like they've asked a question, you kind of feed more into their fears rather than being able to say, why are you hesitant? And giving them a resource, giving them a source that they could actually go to and answer that in a way. So we have a big role in being role models if we ourselves get vaccinated, or just in being able to answer questions. I actually put out on my Facebook group, private message me if you have any questions. My husband's like, you're never going to be off Facebook, you're going to be on there all the time. But I feel like, it's something I need to be able to do. If people have questions, they need somebody to be able to go to. And if I can't always answer them, I can give them somebody to go to, or a lot of times it is our healthcare provider that can answer the specifics of, if you just got an organ transplant, you need to talk to your nephrologist if it was a kidney transplant. So giving them the correct resources.
I'd like to add that revelation, sorry, I was going to add that revelation to our communities, whether it's by Facebook or other methodologies, is working. The Kaiser Family Foundation has done studies early in December. The foundation estimated about 30% of Americans thought they would not have the vaccine, and now it's down to about 20%. So I think we can all play a role in our communities by supporting the vaccine and demonstrating we've had it.
Great. And I did want to go over this, if I could just piggyback, Colleen, for a moment off of this, because we talked about this at the last conversation, but curious about the vaccine again, given the vaccine. So someone who has had the virus, and the question here says, I'm curious about guidance for pregnant women to get the vaccine. So what is our recommendation here for those who've maybe had the virus before, or those who are pregnant?
Two different populations. So the clinical trials for the RNA vaccines did not include pregnant women. They actually required you to have 2 forms of birth control. They did not want that as the first population, like we didn't include children. Despite the fact that we required them to have birth control, we did have, I think it was 28 women did get pregnant. So it is something now that it is considered pregnancy being a higher risk than a non-pregnant woman. So it's a conversation that that person needs to have. Are they in a healthcare setting where they're going to be even higher risk? So now they're pregnant and seeing patients that might have COVID. So it's a conversation to be had with their primary care person, but it is considered an at-risk group that should really consider getting the vaccine. So.
Great. And there is, before I get to a question that kind of is off the vaccines a little bit, there is a question in the Q&A box about vaccines being injected into the arm. And the question is, does the vaccine have to be injected in the arm? If someone is at high risk for lymphedema, could there be an alternate injection site? I was curious if someone could maybe help us out with that one.
Well, what you want to make sure is that you get the vaccine into the muscle. The arm is the easiest way to do that because you've got a big deltoid muscle that goes over your shoulder down into the arm. The problem with getting it into the buttocks or the thigh sometimes is the needle didn't reach into the muscle. So you can use an alternate site, but it really have to make sure that the needle length assessed with a person that'll be given intramuscularly. You don't want to give it subcutaneously or into the adipose tissue. And just you gave two questions. One was about pregnancy and one was about those who had had COVID virus previously. Maybe Dr. Maital wants to tackle that one because I know he dipped into that on the chat.
So if you've had the natural infection, should you get the vaccine?
Right.
Yeah, so right now we don't know what the difference is in response to a natural infection versus a vaccine exposure. So I don't think there's any reason for a person who's had the infection to not get vaccinated. It may very well turn out that it's redundant. You already have protective immunity, but there's no indication whatsoever that having the vaccine after the natural infection will cause the vaccine to be less effective or should cause any problems.
Yeah, and we really don't know how long immunity, so to speak, lasts after clinical infection. I mean, it's rare, but there are individuals who've had second infections after their primary case. So I would say at this point, until we have more data about the natural history of COVID and the differences in immune response between natural infection and vaccine, that you would get the vaccine. I don't think you're in the first priority group to get it, but I would see no contraindication to getting it for now.
So Dr. Eadie, this question is going to go back to you. It's stated that for the upcoming 1B phase, the age criteria was those 75 and older. However, I believe that some press have stated that this 1B rollout was for those 65 years and older. Or is this just for those 65 years and older with pre-existing conditions? Can you clarify a little bit?
Absolutely. So, but before I do, if I can just quickly applaud the university for, as I think it was Dr. Hill who was describing how you guys are going to sort of in a threefold approach, address the COVID status of your students. I mean, I think that's a gold standard. So thank you for that. And then Dr. Tuchera, your DNA earrings are amazing. Thank you. So I think what they may be alluding to is the fact that, and it could have been confusing. So the allocation committee entertained the possibility of bringing in the 1C. So 1C has those 65, it deals with the ages, right? So it goes from 16 to 64 who have comorbidities that places them at high risk. And then from the 64 to the 74, that additional group. And so they were talking about the possibility of including some of the 1C participants in the 1B category. That has not been finalized. And I think that's why the governor said, or the commissioner said today during the press conference, that we may reduce it from maybe slightly from 75 to possibly 65 in 1B. But that, again, that has not been finalized, but will be next week.
Great. Colleen, I'm going to throw this back to you.
Thank you. So Dr. Eadie, one more about those phases and the different workers that we might be vaccinating. There was a question here about service professionals, for example, in salons, hair salons. Where do they fall?
Yeah, so right now, if my memory serves me correctly, I actually don't have the list in front of me. So when you think about the food and agriculture industry, they certainly will be in 1B. Those other workers, as you described, will fall in 1C, and that's classified as the remainder of the essential workers. So 1B are frontline essential workers, and then 1C are the remainder.
Okay, perfect. Thank you. I think that clears that up. Now I need my scientist and epidemiologist to be on call here. There's a question, insightful, about infection rate differences between what we're seeing in the clinical trials and the general population. Someone mentioned that the infection rates seem to be so low in the clinical trials, 1% infection, and then the general population, we're seeing 5%. So anyone want to comment on why that might be?
So one possibility might just be when the clinical trials occurred. So the participants in the clinical trials are members of the community. They are going to be exposed to the virus at a similar rate to all other members of the community. So in clinical trials, you might expect the infection rate to mimic that in the community at that time. So if you look at the clinical trials, you'd have to look at when is that data coming from. You also have to think about, you also have two groups. You have the placebo group that did not get the vaccine, and then the group that did get the vaccine. What we've seen, thankfully, is that the vaccine group has a very low percentage of getting the infection. So that might be a possible reason why we're seeing different rates. I don't know if that answers the question or not.
And that just add that the clinical trials were not just in one region of one country, they were in several countries. So each of those countries was having different exposure to the virus, and it was mostly done at a time that was a bit quieter, certainly in the United States.
I think we had a question, and I wondered if Professor Doyle, Maya, if you mind commenting a little bit on a bit about people's access to this vaccination and concerns that we might have with different populations. We did allude to it earlier, but maybe you could talk a little bit more about that. I'm going to ask you to unmute yourself first.
Sorry about that. I'll answer what I can, and I'm actually going to toss this to Dr. Eadie as well, because I think he was also talking about how Connecticut is thinking about how we make sure that those more vulnerable populations, in terms of particularly communities of color that have been so adversely affected, how we're going to do that in Connecticut. I think that's still an ongoing discussion across the country about how to prioritize the communities that are both, that have been at higher risk and have had higher exposure. So I don't know what the plan is for Connecticut. I know you sort of mentioned that, Dr. Eadie. I assume there are other congregate care and prison populations and things like that where people are close together that we also have to think about. So maybe you can tell us a little bit more about the conversation happening there.
Absolutely, and this is the exact, and this is how tough the allocation committee's subcommittee's job is. I mean, so when we look at the data, and again, we try to let the data drive our decisions, right? So if you go to ct.gov and you look at the deaths, you're going to see, based on age, that 75 and older are dying at a higher rate than other age groups. When you classify or slice the data, I should say, and you look at it by race, then you'll see that the Hispanic or Latinx and African-American communities are dying at a disproportionate rate. And so the question becomes, well, which one is more important, right? And so that's a difficult question to answer. And that's why they have definitively not made that recommendation to the governor. So this is not easy work. We wish we had enough vaccine to give it to everyone right now. We also understand that, those congregate settings or communities that have multi-generations, for example, I mean, those are super spreaders. Those also are households of many of our essential workers. And so these are the same people who can't work from home, like healthcare workers. They've got to go out. We're depending upon them, and they're dying at a faster rate. So that's the balancing act has to be there. And again, this is very, very tough work. So please pray for us.
And if I could just piggyback on that, this vaccine has been shown to have great efficacy in those older populations. So that decision might have been different if those older people, like the flu vaccine, they don't respond as well, or the efficacy in those older populations is very high.
Yeah. And you know, it's also true to make it more complex. In the African American community for Pfizer, the efficacy was 100%. And this is based on Pfizer's data. And then the Latinx community was, I believe this is only Pfizer, 94.5%. So, I mean, you bring that into the conversation, it also makes it more complicated. Not an easy answer, not an easy question to answer.
Thank you. I appreciate you taking the effort to answer that question. I know it is a difficult one. Thanks, Maya, too. I think we have maybe one more, Janelle, or you with, and this one's just kind of straightforward, but I really like it. And people are concerned in the 1B, 1C group, where they're going to get this vaccination. So we know our healthcare workers, the 1As, are going to these more clinical sites or in their own workplace settings. Where are the rest of the people going to go get the vaccine?
You want me to?
Sure.
Sure, I'll take a stab. So another good question, another difficult answer. Here's what I'll say. So, you know, again, the easy part to me was 1A because the hospitals got Pfizer first, right? The ones that had the ultra low freezer capabilities, and then they would be the house that distributed to, if you will, other hospitals that did not have it in the travel pack, which allowed them a few days to store it. Then came Moderna. Moderna has it at, at a much lower temperature, so the common household freezer, if you will, can store that. As we move on, as some of my panelists alluded to earlier, to more manufacturers getting approved, this is when we will expand the number of vaccinators in the state, right? So your doctor's office, for example, just like the influenza or flu vaccine, they will have those vaccines available as well. So as we move from phase 1A to 1B, 1B to C, and then 2, we also anticipate that there'll be more opportunities for vaccinations throughout the state, and that will be how we successfully expand it.
Thank you very much. And I think, Dr. Mittal, you had a concern or question you wanted to bring up about our earlier discussion about variants in our quick few seconds we have left.
I think this just, hopefully ties into, hopefully everyone's feelings, that we're definitely at a time now where we don't want to let down our guard as far as the precautions we're taking. These new variants, they are indeed more highly transmissible. And, the question I got earlier was about the efficacy of the vaccines for the UK variant. And again, there's no indication that would be less effective. There are some, early indications that some of the antibody treatments for the South African variant are less effective, and that may be indicative that the vaccine could be less effective for the South African variant. We have not seen South African variant in the US yet, but just like the UK variant, it will probably show up. So, while we're learning more about these variants and, while we're confident the vaccines will work, and if they don't, the nice thing about the RNA vaccines is that they could be quickly altered. I think Moderna and Pfizer both said about 6 weeks to alter a vaccine if they need to make it, if they need to alter it to make it more effective for these variants. But we, until we know more about these variants, we really need to kind of double down on our precautions as far as decreasing transmission.
Dr. Mittal, panelists, thank you so much. I'm going to kind of leave a final comment, but I want to ask one final quick question. Dr. Eadie, what advice do you have for Connecticut citizens while they await vaccine inoculations?
Yeah, I mean, I think Dr. Mittal, his concluding statements were ideal. We're up against time here, right? So the faster citizens, the faster we get, the more vaccine we get, and the faster citizens roll their sleeves up, the better we're able to deal with the potentially disastrous situation that Dr. Mittal just alluded to. So I think Connecticut, we just need to do the right thing. This is the information. This was a great conversation. Now you need to synthesize that and decide whether or not, or I should say how soon you will be willing to roll up your sleeve and get vaccinated. Thank you.
Dr. Eadie, panelists, thank you. Wear your masks, socially distance, wash your hands. Get the vaccine when you have an opportunity to get the vaccine. We need to get to our herd immunity. Thank you once again to our panelists, and thank you to the participants for being here with us tonight. Dr. Eadie, special thank you to you for being here and providing this important information for our community. I want to take a moment to share some resources for you that we put together that will give you the most updated information regarding COVID vaccines. And I would like you to invite us in the future to join us for our continued COVID-19 vaccine community conversations in the future. This is an ever-changing, evolving pandemic, and the viruses the vaccines too will for sure evolve as we move forward. On behalf of Quinnipiac University and the School of Health Sciences, I wish you health and wellness this new year. Be safe, be well, and go Bobcats.